Today's lecture is International Healthcare Systems. Health systems can be understood in many ways. The World Health Organization defines health systems as all the organizations, institutions, and resources that are devoted to producing health actions. The definition includes the full range of players engaged in the provision and financing of health services, including the public, non-profit, and for-profit private sectors, as well as international and bilateral donors, foundations, and voluntary organizations involved in funding or implementing health activities. Health systems encompass all levels: central, regional, district, community, and household. Health sector projects engage with all levels and elements of the health system and frequently encountered constraints that limit their effectiveness. Health system functions. The World Health Organization identifies the 4 key functions of the health system. Stewardship, often referred to as governance or oversight. Second function is financing. Function number 3, human and physical resources. And number 4, organization and management of service delivery. Stewardship policy and advocacy. The stewardship function reflects the fact that people entrust both their lives and their resources to the health system. The government, in particular, is called upon to play the role of a steward because it spends revenues that people pay through taxes and social insurance, and because government makes many of the regulations that govern the operation of health services in other private and voluntary transactions. The government exercises its stewardship function by developing, implementing, and enforcing policies that affect the other health system functions. World Health Organization has recommended that one of the primary roles of a Ministry of Health is to develop health sector policy with the aims of improving health system performance and promoting the health of the people. Governments have a variety of so-called policy levers they exercise to affect health programs and health outcomes. Government policy and health programs. Governmental policy levels: size of the total government health budget. Relevance to health programs sets the overall limit on what a government can spend. Financing mechanisms for funding the healthcare system. For example, donor support, taxes, user fees, social insurance contributions. Determine what flexibility the government has for financing healthcare and identify potential financial barriers that may exist for accessing care. Example fees, their levels and exemptions. Allocation of the government health budget reflects how the government uses its tax resources to, for example, deliver services, employ staff, subsidize providers, regulate the sector, provide information, and configure the sector in terms of preventive, as curative services, Personal with supplies, investment in human resources, training with physical resources, hospital. Affects which programs are prioritized and what populations will benefit. Rich vs poor, urban vs rural. Regulation of civil society organizations. Can facilitate or constrain the functioning of private voluntary organizations, non-governmental organizations, and community organizations with regard to service delivery and the capacity such groups have to influence and advocate for health services. Political support to raise awareness for specific health messages and behaviors. Clear government support for specific health messages such as prevention of HIV, contraceptive use, or TB treatment. Can be powerful for stigmatized or polemic health initiatives and promoting high-impact health interventions, for example, hand washing. Adoption of specific health standards or guidelines can improve the quality of care, expand or constrain the number of providers, and facilitate implementation of approaches such as integrated management of childhood illness. Regulation of pharmaceuticals can improve medicine quality assurance and rational use of medicines. Can influence the ability to bring medicines and supplies into the country. Business regulations and taxation can influence the degree to which the private sector participates in healthcare. For example, import taxes can affect pharmaceutical sales. Business regulations can hamper private providers from setting up practices. Limitations on advertising can limit promotion of branded health products. An example of strong government stewardship in health can be found in Uganda, where the government's proactive approach to preventing HIV/AIDS is likely to have reduced the incidence of the disease. The government provided an enabling environment by encouraging community-based initiatives and supporting mass communication campaigns, which promoted prevention and behavior change. Furthermore, stewardship in health encompasses: first, activities that go beyond the health system to influence the main determinants of health: education, poverty, environment, and second, other issues that are external to the health system but which either foster or constrain its effectiveness. For example, a government may decide to tax import medicines, to increase general tax revenues, or to protect local producers, but in doing so will increase prices to consumers and impair access to these medicines. Stewardship in this area seeks to influence the broader environment in which the health system operates. Emerging research evidence demonstrates that health is a key component to good development policy. The presence of poor health conditions in a country slows economic growth directly as societies lose potential workers and consumers to disease and disability. Attention to reducing child mortality and morbidity results in healthier children who can attend school and eventually contribute to economic growth when they become wage earners. Priorities in health policy also need to be elaborated at the national and local levels through health goals that address improving the health of the poor and reducing the gap between the poor and non-poor for an impact on child survival. Although the establishment of policy lays an essential foundation for a government's intention, its value depends on the evidence and effects of policy implementation. As such, health system assessment should take account of the degree of government decentralization and the levels and authorities that are the key decision makers in health. Which levels have authority over planning, budgeting, human resources, and capital investment? Is the health sector represented at the district council level? Does the district have a role in policy development, resource allocation, and human resource planning? These dimensions underscore the need to approach health system performance and strengthening by understanding the interaction and linkages that exist between health financing, service delivery, and management of human resources in the health sector. Health financing is a key determinant of health system performance in terms of equity, efficiency, and quality. Health financing encompassed research, mobilization, allocation, and distribution at all levels, national to local, including how providers are paid. Health financing refers to the methods used to mobilize the resources that support basic public health programs, provide access to basic health services, and configure health service delivery systems. Health financing. Understanding health financing can help answer questions such as the following. Are resource mobilization mechanisms equitable? Will they subsidize the poor and those most in need? Is the distribution of resources equitable, efficient, or will there are populations benefiting more from public financing that are poorer populations? Do provider payments reward efficiency and quality? By understanding how the government health system and services are financed, programs and resources can be better directed to strategically complement in-health financing already in place, advocate for financing of needed health priorities, and aid populations to access available resources. The health financing system consists of the payers, providers, and consumers of health service and the policies and regulations that govern their behavior. The simplest example is when the patient pays the provider directly, whereby the consumer and payer are the same person. Sources of health financing. Health systems in developing countries are financed through a mix of public, private, and donor sources. The mix of sources varies widely. Public sources are governments that raise funds through taxes, fees, donor grants, and loans. Typically, the Ministry of Finance allocates general tax revenue to finance the Ministry of Health budget. Most government health budgets are historical. That is, they are based on budgets from previous years that are adjusted annually to account for inflation or at the same rate as most other government spending. These budgets usually have separate line items for personnel, hospitals, pharmaceuticals, supplies, fuel, and training, and they finance only recurrent costs. Capital investments are often found in a separate budget that may be paid for through donor grants or loans. In decentralized health systems, district health authorities are often given power to allocate non-personal, non-capital investment funds at the local level to social sector budgets such as education and health. This flexibility allows for some local priority setting according to needs within social sectors. A few countries use global health budgets that give recipients, district health authority or hospital, discretion over how to allocate the budget. Private sources. Private sources include households and employers who pay fees directly to providers in both public and private sectors, pay insurance premiums, including payroll taxes for social health insurance, and pay into medical savings accounts and to charitable organizations that provide health services. Household out-of-pocket payments form a large source of health financing in many developing countries. The private sector is an important source of health financing in most developing countries. Reliance on user charge financing and the point of service puts a greater burden of ill health on poorer households. In the case of catastrophic health events, the need to pay can impoverish families or cause them to forego treatment. Some information about health insurance systems and mechanisms. Health insurance is a system whereby companies, groups, or individuals pay premiums to an insurance entity to cover medical costs incurred by subscribers. Depending on how an insurance system is structured, it can pool the premium payments from the rich and healthy with the poor and sick to improve equity and thus prevent impoverishment by covering medical costs from catastrophic illness or injury. In the public sector, social health insurance programs are set up as mandatory insurance systems for workers in the formal sector. Social health insurance contributions, which are typically payroll taxes from both employers and employees, are placed in an independent or quasi-independent fund separate from other government finances. Social health insurance contributions may improve equity by mandating larger contributions from higher paid workers. Health insurance systems in low-income countries generally lack the resources to provide wide coverage of quality health services, although some insurance systems have their own facilities or contract with NGOs and commercial providers to expand access. Whereas social insurance primarily pools risk across income groups, private insurance is based on the distribution of risk between the sick and the well. Private insurance is quickly growing in developing countries as the private sector in many regions expands and employers seek ways to provide health insurance to their employees. Now, information about 4 basic systems. There are a lot of countries on our planet, and each country devises its own set of arrangements for meeting the 3 basic goals of a healthcare system: keeping people healthy, treating the sick, and protecting families against financial ruin from medical bills. But we don't have to study 200 different systems to get a picture of how other countries manage healthcare. For all the local variations, healthcare systems tend to follow general patterns. There are four basic systems. First system is the Beverage Model. Second, the Bismarck Model. Number third, the National Health Insurance Model. And the last one is the out-of-pocket model. We will start from the Beverage Model. The Beverage Model, named after William Beveridge, designed Britain's National Health Service. In this system, health care is provided and financed by the government through tax payments. Beverage Model is a nationalized healthcare system. Similar to how public libraries and police forces are financed by the government, healthcare is controlled through citizen tax money. Citizens of countries who utilize this healthcare plan do not directly pay for their medical or other health-related bills. The goal of this plan is to provide quality health care regardless of people's ability to pay for their care. The majority of hospitals and their staff are considered government property and employees respectively. Private doctors and clinics also receive their fees from the government instead of from the citizens. According to physicians for a national health program, this healthcare system has low costs per capita because the national government determines what doctors can do and what they can charge for their services. Characteristics. So, healthcare is a human right, not a privilege. Government ownership and operation of healthcare. National government responsibility for delivery of equitable and efficient healthcare. Full access to all regardless of ability to pay. Primary care physician as gatekeeper to the rest of the system. So, providers and payers are private. Private insurance plans financed jointly by employers and employers through payroll deduction. The plans cover everyone and do not make a profit. Tight regulation of medical services and fees. Cost control. Countries using the Beverage Model: Great Britain, Spain, Denmark, Finland, New Zealand, Hong Kong, Cuba, Italy, Norway, and Sweden. Pros. Every citizen has access to health care because of the universal coverage. The government is responsible for quality of care, and this may be beneficial if the government keeps the cost of health care low. Citizens do not receive and are not responsible for medical bills or co-pay. Cons. Every citizen must pay the higher taxes regardless of their use of health care. The government is responsible for quality of care, and this may be harmful if the government restricts the services patients are allowed access to. There are long waiting lists and lines to receive care, especially for those with non-emergency situations. The Bismarck Model. It is the second model. In 1883, Prussian Chancellor Otto von Bismarck created the Bismarck Model as a social welfare measure for German unification. Principles. His national healthcare model was based on 3 principles. First principle: the government is responsible for universal access to health care. Health policy is implemented by the smallest political and administrative units in society. Elected government officials negotiate the terms of medical care and reflect the interest of different medical professions. In the Bismarck model, the insurance system is financed jointly by employers and employers through payroll taxes called sickness funds. These taxes are directly deducted from paychecks. The United States has adopted a form of the Bismarck model of health care. Most Americans who are employed but not yet eligible for Medicare receive health insurance coverage from their employers as a benefit of employment. However, this approach is not as advanced as the German version because employers limit the list of health insurers that employers can use. Unlike the United States, where employers provide a narrow selection of health insurers, employers can choose from German employees have the option of choosing from over 200 types of sickness funds to pay into. Although countries who employ this model are home to mostly private hospitals and physicians, the Bismarck model is designed for every citizen to be covered and does not aim to make a profit. Private insurance companies, which are required to be non-profit, exist for self-employed citizens and those who wish to receive elective services not covered by sickness funds. This financial implementation makes the Bismarck model a multi-payer system. However, these insurance companies are also heavily regulated by the government. The fact that insurance companies are non-profit and heavily regulated, in addition to fixed price procedures, control costs and keeps them low. In Germany, patients have the ability to choose low-cost drugs at no personal cost or pay the difference if they choose higher-cost drugs, allowing patients to control which medications they wish to use. Both creates competition in the drug industry and keeps the cost of drugs affordable. The price of procedures are negotiated between state representatives and medical associations to make sure the price of procedures and medications are the same throughout the country. Characteristics. Short waits, quality care, relatively low cost. Tight regulation of insurance, which is often, but not always, sold on a non-profit basis. Claims paid without challenge. No exclusion for pre-existing conditions. Prices for most procedures fixed by the state. Private hospitals and physician practice. Healthcare is provided and financed by the state through tax payments. There are no medical bills. Medical treatment is a public service. Providers can be government employees. The government controls costs and the soil payer. The primary criticism of the Bismarck model is how to provide care for those who are unable to work or can't afford contributions, including aging populations and the imbalance between retirees and employees. Countries using the Bismarck model: Germany, Japan, Switzerland, France, Belgium, the Netherlands, parts of Latin America. So, pros: individuals do not need to worry about being uninsured or going broke from expensive healthcare bills. Compared to the US, the administrative costs of this model are much lower. There is little waiting time to receive primary care services. And cons: the focus on low costs and efficient care means there are less healthcare services available for citizens living in rural areas. Mandatory employment taxes are high in order to keep healthcare affordable. There are longer waiting times for patients to receive elective secondary and tertiary services. Next model is the National Health Insurance Model. The National Health Insurance Model blends different aspects of both the Beverage Model and the Bismarck Model. First, like the Beverage Model, the government acts as the single payer for medical procedures. However, like the Bismarck model, providers are private. The National Health Insurance Model is driven by private providers, but the payments come from a government-run insurance program that every citizen pays into. Essentially, the National Health Insurance Model is universal insurance that doesn't make a profit or any claims. This system incorporates two systems, but payment comes from a government-run insurance program that every citizen pays into. Characteristics: National Health Insurance Model control costs by limiting the medical services they will pay for, or by making patients wait to be treated. Since there's no need for marketing, no financial motive to deny claims, and no concern for profit, it's cheaper and much simpler to navigate. This balance between private and public gives hospitals and providers more freedom without the frustrating complexity of insurance plans and policies. The primary criticism of the national health insurance model is the potential for long waiting lists and delays in treatment, which are considered a serious health policy issue. In what countries used this national health insurance model? The classic system is found in Canada and some newly industrialized countries, Taiwan or South Korea. This system strongly influences prices and therefore provider compensation. In Canada, they manage costs with global budgets. About 2/3 of Canadians also buy private insurance to cover services such as dental care and prescription drugs. Most physicians are self-employed and receive fee-for-service payments, although some provinces are experimenting with alternative payment models. The single payer tends to have considerable market power to negotiate for lower prices. Canada's system, for example, has negotiated such low prices from pharmaceutical companies that Americans have spurned their own drug stores to buy pills north of the border. National health insurance plans also control costs by limiting the medical services they will pay for or by making patients wait to be treated. Characteristics: providers are private. PAIR is a state-run insurance program that every citizen pays into. National insurance collects monthly premiums and pays medical bills. Can control costs by limiting the medical services they will pay for or making patients wait to be treated. And the last model is the out-of-pocket model. Countries that do not have established national health care systems make up the majority of the world. Countries that do not enforce medical care are usually too poor or disorganized to provide health care for their citizens. It is usually the rich and powerful who are able to receive care. Those who are too poor must rely on local or untrained healthcare providers. In third world countries and rural areas of South America, Africa, and Asia, many people go without receiving care from doctors. These villages rely on home remedies to fight against sickness and diseases. Citizens of developing countries who live in rural areas must travel far in order to receive affordable health care in the city. The World Health Organization states that formal health insurance in developing countries is rare. Much of the borrowing and saving by households is informal in nature and reliant on the social capital of communities. Many of these places have village healers that are paid in labor, produce, or favors in exchange for traditional medication. People who have nothing are left on their own and cannot pay actual doctor bills. Citizens unable to pay for these out-of-pocket costs are not able to receive care. According to data compiled by the World Health Organization, the countries with some of the highest rates of citizens who pay out-of-pocket costs include Nigeria, Vietnam, Cambodia, and India. The majority of countries that have high rates of citizens who pay out-of-pocket costs are developing or third world countries. However, out-of-pocket costs do exist in countries that have developed their own healthcare systems. The countries with some of the lowest rates of citizens who pay out-of-pocket costs include France, the United Kingdom, New Zealand, and some other countries. The out-of-pocket model is the most disorganized system of healthcare out of the four models mentioned in this lecture. This model cannot ensure that every citizen has access to healthcare, and the people are often left in sickness or incur a huge debt because they cannot afford the pay for medical care. The countries that rely on this archaic out-of-pocket model are in areas that need public health reform in order to function on the same level of success as the three previously mentioned models in this series. So, characteristics. Only the rich get medical care. The poor stay sick or receive minimal services by public and humanitarian institutions. Most medical care is paid for by the patient out of pocket. No insurance or government plan. Health policy. Health policy can be defined as the decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society. According to the World Health Organization, an explicit health policy can achieve several things. It defines a vision for the future, it outlines priorities and the expected roles of different groups, and it builds consensus and informs people. The Russian healthcare system, healthcare in Russia, is provided by the state through the Federal Compulsory Medical Insurance Fund and regulated through the Ministry of Health. Healthcare in Russia is free to all residents through a compulsory state health insurance program. Costs of healthcare in Russia. Russia spent 5.27% of its annual GDP on healthcare. However, this is below to the current global average of around 10%. It is also lower than all EU countries except Romania, Europe countries. Employers finance through contributions. Once you begin working in Russia, your employer will pay around 2-3% of your salary into a social tax, a percentage of which is paid into a national Russian healthcare fund. Once an employer pays this compulsory medical insurance, you have the right to free medical assistance from public Russian healthcare clinics. Those who cannot contribute or are not working, employed, children, those too ill to work, they also can access free basic healthcare, but emergency. Free basic healthcare. In the beginning of our lecture, we told about financing, and there are two models of financing: integration and contract. No, but let's talk about United States health system costs. Largest spend on healthcare, 60% of GDP, 2.3 trillion. Why so high? Providers make more money, high malpractice insurance, the way we manage health insurance, and the complexity of the health system. Only country that relies on profit-making health insurance companies. Private insurance and the industry has the world's highest administrative costs of any healthcare payer in the world. Most fragmented healthcare system in the world. And about Great Britain costs: insured 100% of population insured, spending 7.5% of GDP, funding single payer system funded by general revenues, operates on huge deficit. Private insurance 10% of Britons have private health insurance, similar to coverage by NHC, but gives patients access to high quality of care and reduce waiting times. Physician compensations. Most providers are government employees paid under salary and according to number of listed patients. Physician choice. Patients have very little provider choice. Co-payment, no. Deductibles, almost no co-payments. Waiting times, huge problem. Benefits covered, offer comprehensive coverage. Terminally ill patients may be denied treatment. And some information about a health information system. A health information system refers to a system designed to manage healthcare data. This includes systems that collect, store, manage, and transmit a patient's electronic medical record, EMR, a hospital's operational management, or a system supporting healthcare policy decisions. Health information systems also include those systems that handle data related to the activities of providers and health organizations. As an integrated effort, these may be leveraged to improve patient outcomes, inform research, and influence policy making and decision making. Because health information systems commonly access, process, or maintain large volumes of sensitive data, security is a primary concern. Health information technology involves the development of health information systems. Examples of health information systems. Health information systems can be used by everyone in healthcare, from patients to clinicians to public health officials. They collect data and compile it in a way that can be used to make healthcare decisions. Examples of health information systems include electronic medical record and electronic health record, as EMR and EHR. These two terms are almost used interchangeably. The electronic medical record replaces the paper version of a patient's medical history. The electronic health record includes more health data, test results, and treatments. It also is designed to share data with other electronic health records so other healthcare providers can access a patient's healthcare data. Practice management software. Practice management software helps healthcare providers manage daily operations such as scheduling and billing. Healthcare providers from small practices to hospitals use practice management systems to automate many of the administrative tasks. A master patient index, MPI, connects separate patient records across databases. The index has a record for each patient that is registered at a healthcare organization and indexes all other records for that patient. Master patient index are used to reduce duplicate patient records and inaccurate patient information that can lead to claim denials. Patient portals. Patient portals allow patients to access their personal health data such as appointment information, medications, and lab results over an internet connection. Some patient portals allow active communication with their physicians, prescription refill requests, and the ability to schedule appointments. Remote patient monitoring, also known as telehealth, remote patient monitoring allows medical sensors to send patient data to healthcare professionals. It frequently monitors blood glucose levels and blood pressure for patients with chronic conditions. The data is used to detect medical events that require intervention and can possibly become part of a larger population health study. Clinical decision support. Clinical decision support systems analyze data from various clinical and administrative systems to help healthcare providers make clinical decisions. The data can help prepare diagnosis or predict medical events, such as drug interactions. These tools filter data and information to help clinicians care for individual patients. Benefits of health information systems. Health information systems tend to target efficiency and data management. The main drivers of health information systems are data analytics. The healthcare industry constantly produces data. Health information systems help gather, compile, and analyze health data to help manage population health and reduce healthcare costs. Then the healthcare data analysis can improve patient care. Collaborative care. Patients often need to treatments from different healthcare providers. Health information systems, such as health information exchanges, allow healthcare facilities to access common health records. Cost control. Using digital networks to exchange healthcare data creates efficiencies and cost savings. When regional markets use health information exchanges to share data, healthcare providers see reduced costs. On a smaller scale, hospitals aim for the same efficiencies with electronic health records. Population health management. Health information systems can aggregate patient data, analyze it, and identify trends in populations. The technology also works in reverse. Clinical decision support systems can use big data to help diagnose individual patients and treat them. Так, today's present. Muskan Drundval, Ridhi Shavdam. Значит, 14, 15, 16 group. Parul Sharma, Sampath Prasad, Deepak Dwivedi, Chandini Groda, 21st group Saranya, and Altamash Madni. Так, this one. Deepak Dwivedi, окей.